We're absolutely delighted to be here for today's really important session, the importance of sleep in children with TSC. So we know from our experience at the TSA, so my name is Luke, and I'm Head of Support and Communications at the TSA. So in our support services, we do get lots of questions about this, about sleep, and also the impact of sleep on children who live with TSC. Everyone can benefit from a good night's sleep, can't they? In particular in the TSC community, I think. And we're so pleased to have with us to lead tonight's discussion, Dr. Stacey Bissell and Dr. Caroline Richards from the University of Birmingham, and also Dr. Catherine Hill from the University of Southampton as well. Before I hand over to our fantastic speakers, just some very quick housekeeping. So just so you know, we're recording this event, which you probably heard from the very weird automated voice that happens at the beginning of the Zoom calls now, which they've just started to put in for whatever reason. If you prefer you weren't on the recording, that's absolutely fine. It's no problem at all. Just let me know, and we can cut you out of any sort of discussions or questions that you have. It's no problem. What we tend to ask people to do is just to keep yourselves on mute unless you have a question or something to add. Then obviously you can unmute yourself or put your hand up or whatever, and we'll get to you. And yeah, that's everything from me. So I will then hand over to Stacey, Caroline, and Kathy for their presentation.
Hi, can everyone see the screen?
Yeah.
Yeah, okay. Hi, my name is Stacey. I'm a researcher from the University of Birmingham, and I'm so honoured to be here, and thank you to the TSA for inviting me. It's really mad because Marie was one of the first people that I met about 7 years ago at a TSA event in Birmingham. So I will quickly discuss sleep research specifically in TSC and how our work at Birmingham fits into the current sleep literature, with some overview of behaviour and potential interventions for sleep. So this will have a very different focus to the TSA sleep webinar that you may have attended last May, because we will specifically be talking about TSC specific research in relation to sleep. And then after my talk, we will have a Q&A. So Dr. Caroline Richards is a clinical psychologist and Dr. Kathy Hill is a consultant in paediatric sleep medicine, so they can answer more specific questions. So as we know, TSC is a complex and variable disorder, and any of these comorbid conditions listed here in and of themselves are related to poor sleep. And although there are good research articles for any of these in isolation, we know that in TSC, all 4 of these factors can occur. So if we take intellectual disability as an example, sleep problems in children with ID are more chronic and severe than we see in typical development. So sleep problems in and of themselves are very varied and complex. So when we're talking about sleep problems, here are some of the sleep problems that we're talking about. So we could be talking about insomnia, which is difficulty getting to sleep, but we could also be talking about parasomnias, which are things like nightmares, sleepwalking, for example. And this is why the prevalence rate listed here, 54 to 99% for more prevalent sleep problems in intellectual disability, is so varied, because sleep in and of itself is a complex biological process. So when we are thinking about TSC specific sleep problems, beyond having autism or an epilepsy diagnosis that elevate risk for poor sleep, if we take, for example, this meta-analysis of existing sleep literature out there across syndrome groups exploring sleep in genetic syndromes, TSC was investigated as one of the syndrome groups. So a meta-analysis is a synthesis of all the existing literature that's out there on sleep in TSC. So there are 2 things that stand out. So first is that the sleep profile of TSC here, so we're looking for the pluses in this table, is very different from, say, for example, Down syndrome. So in TSC, what stands out is insomnia and excessive daytime sleepiness. So this is very different to Down syndrome, where there are some pluses for teeth grinding and also sleep-related breathing difficulties. They aren't necessarily highlighted for TSC. So where there were 2 pluses, that was where the author was concluding that these sleep problems should be considered a clinical priority. So this idea of clinical priority is really important when we are thinking about TAND. So TAND stands for TSC associated neuropsychiatric disorders. So the coining of TAND was a real turning point for TSC and behavioural research. So it was a turning point because it drew attention to the need for assessment and priorities for treatment when we're talking about behaviour in TSC. And this was really important because we found that only 20% of individuals with TSC are actually assessed and treated for TAND. So why should we care about this in relation to sleep in TSC? Well, on this graphic, you can see that sleep problems are actually listed under the behavioural level of TAND. And by this notion, this then suggests to us that sleep problems are of clinical concern, but also that they're undertreated because of what was highlighted on the previous slide. And there is research from the Tosca registry to actually back that up. So in this table highlights TAND checklist data from over 2,000 people living with TSC worldwide. And the first thing to point out is that very few had existing data on their TAND behaviours prior to this study. So also to bear in mind, this registry is comprised of both children and adults with TSC. And we can see here that some behaviours were more prevalent in children than adults, and those are highlighted in yellow. And also that some behaviours were more prevalent in adults than children, and they're highlighted in green. But here we see sleep difficulties. The 2 things to highlight is that sleep difficulties were the second most prevalent TAND manifestation, occurring in 44% of individuals, but also that sleep problems were not more prevalent in children compared to adults or adults compared to children, that they were consistently prevalent across the board. So in more recent years, there's been a strong focus on priority treatment and assessment of TAND. So that TAND, including poor sleep as an aspect of TAND, should be monitored regularly in clinic using the TAND checklist, but also that treatment of TAND behaviours should follow NICE guidelines. So for ease on this slide, there are a few proactive things that we can suggest doing if you are a parent worried about your child's sleep. So the first thing you can do is download the TAND checklist using this QR code. And you can take that to your clinician at your TSC clinic to talk through TAND, including sleep. But you could also consider keeping a sleep diary to document your child's sleep using this template from the Cerebra guide that we developed. And you can download the guide using the second QR code here. So I'm going to be mentioning the sleep guide quite consistently throughout this presentation, but it is available to freely download. So if you remember from the slide before, clinicians working with your children addressing TAND behaviours should also be following the NICE guidelines for challenging behaviour. And so these are the NICE guidelines that they're referring to. And interestingly, what you can see here is that sleep and co-occurring health problems are highlighted as factors that may underlie some of the behaviours that we see in TSC, such as self-injury, aggression, for example. So quickly, I'm going to present some resources here to think about pain in relation to TSC. So coexisting health problems were highlighted as a factor that may be associated with some behaviour. So if you are worried that your child is in pain and that may be underlying some of their poor sleep, or they are unable to communicate to you verbally that they are in pain, you can download something called the FLAC pain scale using the QR code here. But again, this is freely available from Cerebra. And this is a behavioural observation tool to assess behavioural indicators of pain that you as a parent can observe for in like a 10-minute behavioural observation. But again, in the sleep guide, We've also already considered pain as a factor in relation to poor sleep and intellectual disability. So as you can see here, we've listed pain, incontinence, seizures as some factors that may be underlying poor sleep in the children that we work with. So it is interesting that poor sleep is listed here in the NICE recommendations, because in TSC, poor sleep in itself is a behaviour listed within the umbrella term of TAND. And so poor sleep as a behaviour in itself is incredibly challenging to families who are sleep deprived, and it's incredibly challenging for the child who isn't getting enough sleep. So to list it as a recommendation here, it also shows to us that poor sleep may underlie some other TAND behaviours that we see in TSC as well. So let's first consider poor sleep in itself as a behaviour. So this is sometimes quite a tricky theoretical concept, that sleep problems in some cases may occur because of a behavioural model. So again, back to the Cerebrosleep guide, we also go into more detail within that guide. But here we're talking about learning circles and reinforcement, and this idea of mutual reinforcement. So this behavioural model of poor sleep largely applies to children who may have trouble settling to sleep or getting back off to sleep when they wake in the middle of the night. So I'm quickly going to talk through the behavioural model as an example of how poor sleep in some cases, but not all cases, may be behaviourally reinforced. So let's consider here that a child wakes up in the middle of the night and then they start to cry for their parent because they're waking up in the middle of the night. The parent experiences this child's behaviour as aversive. It's the middle of the night, there may be other people sleeping in the house. And so the parent has to act. So the child may be having a seizure, may need to go to the toilet, for example. So the parent in some way acts in response to the child waking. And the parent will engage with that child naturally as they would. This in itself can be unintentionally, and we're never suggesting that any of this is a conscious act, but this could unintentionally be rewarding for the child. This interaction when they've woken at night may increase the likelihood that when they're on another night, when your child wakes up in the middle of the night, that they might show the same behaviour, because the waking stops and the child settled back to sleep. This is also rewarding for the parent, because your response to your child's waking or challenging behaviour has worked. And so it also increases your likelihood that when your child wakes in the middle of the night, that you will act in the same way. So the parent and child can get locked in this mutually reinforcing behavioural cycle that happens at sleep. But as I say, this isn't the case for all children and all sleep problems in TSC. And it's unlikely to tell the whole story in TSC. And that's because there are additional factors that are specific to TSC and specific biological factors that we need to hold in mind. So the main one being the impact of epilepsy on sleep. So in particular, nocturnal seizures and the effect of anti-epileptic medication in relation to drowsiness. So seizures, taking anti-epileptic medication, are likely to be key factors underlying poor sleep in some children with TSC, and I'm going to return to this later in the presentation. But what I also want to briefly cover is the concept of poor sleep underlying other TAND behaviours that we consider challenging in TSC. So this is a very, very complicated graphic of all the known associations of factors that may underlie the presentation of sleep, of challenging behaviour in TSC. And I investigated this as part of my PhD a few years ago. And we can see that pain and underlying health conditions have been researched in relation to the manifestation of TAND behaviours. But crucially, what's missing from this graphic is the contribution of sleep as a physiological variable that can impact behaviour in TSC. So since my PhD, researchers at the University of Birmingham, led by Caroline, did investigate these associations. And this particular research study found that children with TSC evidence reflux which was associated with higher sleep onset latency, so that's taking longer to fall asleep, and more frequent night wake-ins. But also that night wake-ins and parasomnias, so these are night terrors, sleepwalking, sleep talking, for example, were associated with higher rates of overactivity in TSC, and this was specific to TSC. So pain caused by reflux can underlie poor sleep, and poor sleep may underlie overactivity in TSC. What this study also did was compare the profile of sleep problems in TSC to what we see in age-matched typical development. So the more pluses that you see on this table means the more severe that sleep problem is compared to typical development. So surprisingly, with everything that I've talked about so far, sorry, I just need to move the faces. So surprisingly, with everything that I've just talked about in relation to poor sleep in TSC, this study found relatively small effect sizes. So there are fewer pluses showing small effect sizes compared to typical development, suggesting that sleep wasn't vastly problematic compared to typical development, or at least not as much as we would expect given the previous research. So for example, if we compare the TSC profile to Smith-Magenis syndrome, where there are more pluses associated with these sleep problems, the data does seem to suggest that TSC and sleep might not be as big an issue as we're led to believe, which I don't think is the case. So one reason for this may be because this study used caregiver questionnaires, which are great, but rather than using direct measures of sleep, and so the issue potentially with caregiver questionnaires is that the caregiver isn't always there to observe every child waking, or may not even know that their child woken at night, for example. So we are interested in direct assessments of sleep as well. And here are some direct assessments that we use to measure sleep. So polysomnography would be what you would see in a sleep clinic or an overnight sleep laboratory study. And that is quite intense and quite invasive. The child's not in their normal sleeping environment, they're in an unfamiliar environment, and that might be very difficult for some of our children. So what our research favours is the use of actigraphy. So actigraphy is where we ask children to wear an activity monitor called an ActiWatch. And we ask children to wear this day and night to measure sleep and wake. I'm really sorry, I'm just very conscious that there's a lot of information going on. So I'm just going to, what I'm going to present now is an actigraph, and this is very, very complicated. So I will present this quite slowly because it's quite a difficult concept when you're seeing an actigraph for the first time. So when a child has worn an ActiWatch, this is the data that gets pulled from the ActiWatch when we get it back. So where you can see the black spikes, that indicates to us levels of activity. So you see that that happens more in the day than at night. And then these blue bars indicate low levels of movement. And these are our calculated sleep periods. So this is when the ActiWatch is telling us that the child is asleep because there's less activity. So from this, we can observe a child's bedtime. So that's the start of the blue bar. And then we can also observe their get-up time, because when we start to see black spikes of activity, that tells us that the child's sleep period is over. And we use this blue bar to give us their overall sleep time. But what we're also interested in is when these black spikes of activity occur within the blue bars of sleep, because this is telling us that the child is active when they should be asleep. So this is called wake after sleep onset. So this shows us that the child's showing movement or activity, waking up in the middle of the night during their sleep period. And this brings us on to the eSnore study. So as part of this study that's funded by Bailey Thomas, we are using Actigraphy to directly study sleep in children in the UK living with TSC aged 4 to 15 years. And we're also comparing their sleep profile to typically developing children who are also wearing the ActiWatches. So both groups wear an ActiWatch, and this is a completely remote study of sleep in your child's own bed, in their own bedroom, with everything completed by the caregiver online, over the phone, or via a mobile app. So we are still recruiting for the eSnore study, which is where children are asked to wear this ActiWatch. So if you do have a child with TSC and are interested in taking part in eSnore, you can scan the QR code here and it will take you directly to the online study information, but you can also contact me if you are interested in taking part. And in this study, we are addressing the idea that sleep in itself is a TAN behaviour, so exploring the profile of sleep in TSC compared to typical development, but also that sleep may underlie some of the other behaviours that we see in TSC, such as self-injury, aggression, or overactivity. So as part of eSnore, we first ask caregivers to complete some online behavioural and sleep online questionnaires, and then a telephone interview with me about epilepsy severity and level of ability, and then a 10-day direct remote sleep assessment. So that's the wearing of the ActiWatch. So children wear an ActiWatch, and this is worn consistently over consecutive nights for at least 7 nights. And as you remember from before, I said sleep in TSC requires some additional understanding because of this presentation of seizures. And we are already seeing some evidence of this in eSnore when we look at some of that preliminary Actigraph data. So this is an Actigraph of a typically developing 5-year-old male, and we see fairly consistent extended blue periods of those blue bars of sleep. And this sleep tends to occur around the same time each night with these extended blue periods of fairly good sleep. It looks very different in TSC. So if we then compare this to a 5-year-old male with TSC, we see this more fragmented, broken pattern of sleep, which is very specific, we think, to TSC. So here we see the child was waking very early, sometimes around 4 or 5 a.m., getting up and going downstairs, taking their anti-epileptic medication with breakfast, and then having periods of late morning napping at around 11 a.m. And this seems to be very specific to the profile of seizures and the taking of anti-epileptic medication that's associated with drowsiness. So if we go back to this behavioural model, and as I said, this behavioural model can't explain every single sleep disorder in every single child with TSC, but there may be some TSC specific factors that may preempt this night waking that we do see in children with TSC. So with some suggestion from previous research that pain associated with reflux, for example, or nocturnal seizures are important factors to consider as things that preempt waking, early morning waking, or waking throughout the night. So I'm now going to wrap up my talk just by saying that we are still recruiting, but we're only recruiting for the next month or so. So we're wrapping up eSnore by summer. But please do contact me if you are interested in taking part. And also to say that tomorrow is our Cerebra Network online launch event, which is showcasing our research in genetic syndrome groups across Birmingham, Aston, Warwick, and the University of Surrey. So we have a family focused session tomorrow morning and a research focused session tomorrow afternoon, where we're also again discussing sleep and behaviour. So if you would like to hear about our research or more about our work with TSC, there is still time to register using this QR code. So yeah, very excited to see you there if you have time to attend. But thank you so much for listening. I know that was quite a heavy research, heavy talk. And thank you to the TSA for hosting.
Thank you very much, Stacey. That was great, really interesting. And what we'll do in terms of eSnore, we can share details with everyone signed up for today's event, so they can see more info as well. So we can open up now for questions from anyone for Stacey, Caroline, and Kathy. Though I do caveat was saying that any questions that are asked, it may be that in the long run you may wish to speak to any consultants or anyone who knows you and your family in particular. But yes, I'll be more than happy to have any questions now. Oh, I can see that there was a question about recordings. Oh, okay. Thank you. You beat me to it, Caroline and Stacey. Was there any questions from tonight? Yes, Marie, go for it.
Hi, hello everyone. Thank you very much, Stacey. That was a very, very interesting session. Been dealing with sleep issues for the best part of 34 years here, and I've learned a lot tonight, so I shall be looking at those Cerebra guidance. So thank you for pointing those out in the talk. I noticed that the study is up to the age of 15. You mentioned in the talk that sleep-related issues span children and adults. And I'm just wondering, you know, as a parent of an adult now who still has sleep issues, I really very much welcome the opportunity to get involved in research work that's related to adult problems, because the fundamental issues of the epilepsy and pain and anxieties, they're there still as adults, and in fact they're probably intensified with difficulties with adults sleeping. Bedtime this morning was 5:30, which isn't unusual at all. In lots of ways it's got easier over the years because we have no demands of school or working life anymore. We're just able to sleep when he does, and that makes things significantly easier to manage, and even more so with the restrictions on going out and about and people coming into the home recently over the last year or so. So it's manageable, but it's not ideal. So anything that can, you know, shed light on making things easier for parents of adults as well would be very much welcomed, as I said.
Yeah, so you're right. We as part of the Cerebra network, we do focus more on children, but there is an Actigraphy study that Anna Janssen is currently doing in Europe, and that's still ongoing at the minute. But hopefully there will be some data coming out that's specific to an adult actigraphy study.
Yeah.
The other thing I'd add is that I think although as the Cerebra network, we are, so some of the research we do is with children, we're also really interested in longer term outcomes. And, you know, very often when we're meeting families for the first time and they've, you know, recently had a diagnosis, often the first questions they want answers to are, but what's this going to be like in 10 years for my son or my daughter? What's it going to be like in 20 years? And so one of the very large projects that we're doing that will be ongoing is to every couple of years ask people to tell us again a bit about their child, and we'll do that all the way through adulthood. So that study will be launching in the autumn of this year. We will definitely get in contact with the TSA and make sure it's on your website so you guys can access it, because we really want to follow the children and adults with TSC through into their adulthood.
Brilliant, thank you. I thought it was really interesting, the link with the learnt patterns of behaviours with nighttime waking, and for us, I think although there's a complex mix of issues, I think the main one is the anxiety about nocturnal seizures associated with going to sleep, and that's huge, and we've tried for years and years to resolve that one, and failed miserably so far. And you know, the issue of adding medication to the mix is, yes, it's a possibility, but with a high load of medication already being taken because of the seizures and other issues, then, you know, adding something else to suppress the breathing, for instance, isn't ideal for adults who are struggling anyway.
Yeah, I think that the mixture and the complexity of trying to manage seizures well and have kind of good sleep practices that allow the whole family to sleep that is really, really challenging. I'm not going to talk to medication because that's not my background at all, but some of the other families that we've worked with who also have children with epilepsy have, and I'm sure you've tried this, but have kind of commented on how sometimes the kind of video sleep monitors that kind of came in the last decade for newborn children, those can be quite helpful just in terms of preventing them from developing those unhelpful sleep associations where they have to go in to check. So being able to check on a video monitor so that you don't go in and have that interaction with the child where it's not needed, or the adult where it's not needed. Yeah, some of the families we've worked with who have Angelman syndrome, another syndrome where there's a lot of seizure activity at night, have mentioned that's helpful, but it's absolutely not a one size fits all.
No, indeed. Thank you.
Stacey, sorry. Can I just make a quick comment on that actually before we hear more? I'm really interested, Marie, to hear you going straight for that sort of point about your personal experience of anxiety, you know, when your child or young person has epilepsy at night, because certainly in our sleep clinic practice, that's what we hear again and again and again. In children with all kinds of different neurodevelopmental disorders. And sometimes, you know, while there are, I'm sure, some syndrome specific things, and it is really the work that Caroline and Stacey are heading up is incredibly important to try and kind of tease out these specificities. At the same time, there's also commonalities. And I always say, you know, children are children, parents are parents, irrespective of the name that's given to whatever problem the child has, and sort of running through all of that are these very common issues, and particularly around anxiety, and that lovely cycle that Stacey talked about, that kind of dance between parent and child. I think when your child has epilepsy, it does become very difficult to reassure yourself and to reassure the child that it's okay and that they can settle themselves independently and they can sleep independently if that's what you choose for your child to do. Yeah, so it's a really, really difficult one. It's a tricky one, and you know, like Caroline, we hear quite often parents finding all kinds of clever ways of remotely monitoring or sort of keeping an eye on things without that being obvious. There isn't the magic solution, is there? Because the problem is you do have to keep an eye on, and if you're keeping an eye on, you have to be awake. So that's kind of not totally ideal either, but it's slightly better than going in the room. Yeah.
No, one of our seizure protocols is after a tonic-clonic, we have to stay awake and alert and by his side monitor breathing because of the risk of SUDEP. So it is a tricky one, very tricky.
Yeah,
yes,
yeah. Absolutely.
Yes.
Alice and Finley's mum had a question. You're lovely to settle somewhere by the look of it.
Stacey, could I ask something?
Yeah, go for it.
Sorry, hiya. I'm really interested in this ActiWatch because my little boy Elliot, he's 5. But interestingly, he doesn't actually have seizures anymore and hasn't done for about 4 years now. He was on Vigabatrin to start with, and then obviously after the wean, the seizures have never returned. But he is massively anxious going to sleep, and he wakes up, 3, 4, 5 times a night, and then he is up at 4 in the morning, and it's really, really strange, his sleep behaviour. So I was just finding that really interesting, where because he's not actually waking because he's having a seizure, or so yeah, our situation's slightly different because he's not having them anymore.
Yeah, and so we did some, one of our students did a preliminary analysis where it wasn't really looking like, again, that sleep was, we couldn't really tease it out compared to typical development, and we were thinking that maybe we weren't capturing things at group level, but I think we had a relatively low sample of children having seizures, and then this is relatively new data, and it doesn't represent TSC as a whole. It's just some of the children, this very specific profile is mentioned it a few times, but it doesn't speak to TSC overall. So yeah. If you did want to take part and for Elliot to wear the ActiWatch, we're not suggesting that seizures are the only thing that's going on. Essentially why there's so much variability in TSC, that we were struggling to pick things out at group level because we wanted to sort of tease out these factors a little bit more, and we sort of didn't have the sample size back then to do that. Whereas the more people that that take part with, you know, high seizure rates, low seizure rates, well-controlled seizures, children of different ages with TSC1, TSC2. We're sort of really keen to capture the TSC landscape, I guess, because the seizures aren't the only issue, reflux isn't the only issue, anxiety is not the only issues. It's very complicated. So if you did want Elliot to wear the ActiWatch, then do contact me.
Yes, yeah, we'll do, definitely. Thank you.
Perhaps one thing just to add to that, and I think perhaps parents don't always get told about this, and that is that it's actually completely normal for children to wake up. And that sounds really odd and really contrary, but you know, normal sleep physiology predicts that about once an hour after children have had their nice little bit of deep sleep at the beginning of the night, they will wake up, and we do as well. We all do. It's just we don't necessarily kind of remember the wake-ups. And one of the kind of skills that children learn as they kind of progress from being, you know, those little babies that wake up all the time to being sort of children that are able to sleep more stably, is they learn when they have those little wake-ups that it's night time and that they're safe and they're okay and they can settle themselves back to sleep. So sometimes it's almost that they haven't quite learnt that yet. So there are some children where, you know, assuming there's no pain or they haven't had a seizure and actually they're okay in themselves and they haven't got reflux or any of those other things that Stacey mentioned, it might just be that they haven't quite learnt that trick of being able to settle themselves back down again.
Yeah, that's interesting. We have a monitor on him, but I feel like he uses that to play against us a little bit. He's always like, "Mummy, Daddy, are you awake? Are you awake?" And yeah, I sometimes think, oh, should we take that away? It's a really difficult one because he's so anxious. It's like, don't shut the door, and there's a whole list of things that he kind of plays on. So yeah, even putting his TS to the side, I feel like it just plays on him. This whole anxiety.
Tricky line to tread, isn't it?
Yeah. And then throw a 1-year-old in the mix as well. So it's all a bit, who's constantly waking as well. They're like tag team. But anyway, yes. So yeah,
you must be shattered.
Surprised.
Yeah.
At the minute. But yeah, we're still smiling. So yeah, I was just really interested in that, the graphs and things, because Elliot doesn't have the seizures. So it was just, interesting to see. So thank you.
I also didn't mention, which I should have done, and maybe it was helpful then to spend a bit of time talking about the Actigraph, but we give you a feedback report of that for your child's sleep. So you'll be able to look at his Actigraph and see that, oh, he looked like there was a bit of activity on this night, and we can point those out on the feedback report that we make for you. So
okay,
thank you. The other thing you might want to have a little look at is as well as the sleep guide that's on the Cerebra website, one of our colleagues, Jane Waite, has written a similar guide all about anxiety in children who have neurodevelopmental conditions, which is, again, like sleep problems, not uncommon. And I guess clinically, if a child is naturally anxious, that experience of being separated from parents to go to sleep in a room that might be dark, in a room where they might be able to hear noises but not be quite able to work out what they all are, it is a kind of prime situation for a more anxious child to become even more anxious. And the anxiety guide, again, freely available on the Cerebra website, has got lots of lovely ideas around how you might work out what particularly the triggers are for your child around anxiety, but also some things that can help. So, you know, common techniques for sleep anxiety, especially if it's about separation from mum and dad, can be having, you know, a particular toy that you spray with your perfume that goes with your child to bed and that helps them feel like you are close, or, you know, lots of kind of ideas like that. But that might be worth a look as a guide for some ideas.
Oh, what's that on? Sorry, Caroline.
So that's also on the Cerebra website. I'll find the link and pop it in the chat, actually.
Thank you.
We can share that after the event as well to make sure that everyone has it.
Thank you, Luke.
Thank you.
It's not a question, it's just more of a comment that I was just thinking of there. It would be interesting to see if where there are perhaps siblings and one sibling lives with, for example, TSC, how if any sleep disorders that child has, if there are mimicked or somewhat similar issues in the sibling, if that happens or not. I don't know if there's any research on that or not, but I was just thinking that would be interesting to see.
You should be a researcher. That's a really interesting question.
Having a wry smile, because I think we were talking about that exact idea in a conversation Stacey and I were having about applications for future research funding and whether sibling sleep might actually be quite an important thing for us to look at. So as far as I know, nobody's doing that in any of the groups that we work with. And clearly as parents, it's such an, your child with TSC doesn't live in isolation. If you have other children, there's a whole family around that child that are impacted when they're not able to sleep. So
yeah,
I think that's something to tease apart when if you do look at published research studies and they have contrasted sleep to a control group. Sometimes researchers will use sibling controls, and that potentially skew it. So sometimes that's a really good point to make, that whether these are how are this control group recruited, are they siblings or not, because there are lots of environmental factors within the bedroom or home setting to take into account.
We did a piece of work a few years ago with children with autism spectrum disorder. It was about 40 children and actually looked at exactly that. This was just parental reports, so it was based on questionnaires rather than actigraphy. But it made exactly the point that you've just stated, Stacey, that there was big differences, as you'd expect, between the sleep of children with autism and children without. That's not news. But the siblings who didn't have autism, guess what? Their sleep was actually worse than the control, significantly worse, but not quite as bad as the children with autism. And these were definitely not children who were on the spectrum. These were children that were not on the spectrum. So I think whether that's environmental or whether that's genetic, what that is wasn't really clear. We didn't look at that, but I think you're absolutely right.
That's similar somewhat to what we are always aware of that at the TSA as a whole, to ensure that the siblings in the family unit are always considered. And there's great charities such as SIBS that are absolutely brilliant for stuff like that. Lovely. Is there any more questions or comments for our panel tonight? No, last chance. Lovely. Okay then. Well, in that case, thank you very much, Stacey, Caroline, and Kathy. It's been really interesting, and it's nice to see such great discussions afterwards as well. As I said, I'll share the details of the links that have been discussed tonight, and I'll also share Stacey's details if anyone is interested in EastNOT. And other than that, yeah, just keep an eye on the work of the TSA. We'll be keeping everyone updated on EastNOT and other sleep-related studies and everything else, I'm sure. And we'll no doubt be back sooner rather than later with further events. So thank you everyone for coming tonight, and yeah, hope you have a good one.
Thank you so much for having us.
Bye.
Bye.